Now, we address a topic which is a very important topic called the clinical utility of newly introduced anti-hepatitis B drug in Egypt. It is newly introduced in Egypt, but it was approved for HIV in 2015 and approved for hepatitis B in 2016. So by now, we know that this drug is TAF or tenofovir alafenamide, which is the same efficacy and safety profile with the same resistance pattern as tenofovir, but with no side effects on the kidney, on the bone, and with the least drug-drug interactions. And so this talk is not meant to convey complex informations about these drugs, which is now a fact, but it is to show the clinicians how to use this drug to manage the hepatitis B as a part of the chronic liver disease in Egypt and all the whole world. So we have to discuss what's called one size fits all, the false impressions, lack of specialized hepatologists, primary care physicians, multidisciplinary team, recognition, identification, and linkage to care, and lastly, and not least, in the model systems. دي جملة بالعربي. الحكمة هي الإصابة بالظن وإدراك ما سيكون بالنظر في مكان. One size fits all. We have the praziquantel, for example, which is one drug with the same dose distributed by the primary care physicians for all persons in rural areas. This leads to decreased prevalence of schistosomiasis in Egypt, almost to 0.5%. And this also occurring with hepatitis C virus. And this leads to a false impression that chronic liver diseases is now decreasing and they may disappear completely in the near future. And so this may produce some lack of a specialized hepatologist in the Egypt and in the whole world. The role of primary care physicians consequently will be maximized among a multidisciplinary team to recognize, identify, and link chronic liver disease patient to care in a model systems. Nowadays, HBV is the next challenge after the near eradication of hepatitis C virus, which is expected to occur in 2025. But as we all see, there is many compounds in development for chronic hepatitis B, but the expected cure in the future is by combination of so many drugs in the next 5 years. Unfortunately, these agents are not yet available or even foreseeable. Even in the presence of vaccine, the widespread implementation is still lacking, and still the incidence of hepatitis B infection is a global problem. And this is illustrated in this slide by Patrick Marsland here in Egypt. He presented this talk. The hepatitis B virus nowadays constitutes 42% of all chronic liver disease cases all over the world, and the NASH constituted about 10%. And I'll show you what is the relation between NASH, hepatitis B, and this new drug. It is expected in 5 years duration to decrease hepatitis B virus, but still it constitutes 35% of chronic liver diseases in the world, while the NAFLD increases to 20%. What is the relation between this and what is the situation in Egypt? Here in Egypt, we are an area of immediate prevalence where the transmission is mainly perinatal. And so 90% of infected children will be chronic, and they remain in the immunotolerant state for their 35 years or more. And when they begin to be treated, they are almost about to have diabetes, hypertension, obesity, and expected renal or bone diseases. Moreover, in Egypt, we depend on lamivudine for a long time before, and so most of the patients have now lamivudine resistance, and even if this patient is treatment naive, he is already infected from a person who have a strain which is already resistant to lamivudine. Now I'll show you in Egypt, the liver disease, liver cancer constitutes 14% for total causes of deaths, and it is expected for the obesity on Egypt to increase. It is now 41.7% of adults are obese. The diabetes in Egypt now is 8.2 million person, and it is expected to be 16.7 million in the near future. And the deaths from the complication 40 to 60% before the age of 60, and the prevalence of NAFLD in Egypt is now more than 30%. And so you will be encountered most cases with lamivudine resistant cases in persons exposed to renal and bone disease if they are not already have it, and they will be polymedicated. We have fear of drug-drug interaction and the patient compliance in the presence of polymedications. Also, the cost effectiveness of those medications is questionable. And so the healthcare provider would be the primary care, specialty, tertiary, diabetologist, hepatologist, nephrologist, cardiologist, and even gynecologist for cases of pregnancy, behavior therapy, and dietitians. And so how to implement this in the treatment of hepatitis B virus in Egypt? The first line treatment, as you see, entecavir, tenofovir, alafenamide, and tenofovir dipoxivir, pegylated interferon, adivovir, and tilbivudine. Tilbivudine never come in Egypt. Adivovir is now not present, and also peg interferon because they are not used in Egypt extensively. So we are left with entecavir, tenofovir, alafenamide, and dipoxivir. And the footnote stated that they all have favorable safety and resistance profile. Yet, I'll show you the dosing of preferred nucleoside analog therapies. You find the lowest dose by day permitted according to the creatinine clearance. I want to show you that the tenofovir alafenamide, the lowest dose available is 25, and it needs no dose adjustment according to creatinine clearance till 15. So if this drug is prescribed to a patient with renal disease, you don't have to every now and then calculate the creatinine clearance, or every now and then to modify the dose of tenofovir alafenamide unless the creatinine clearance goes below 50. Moreover, this is the summary of the studies showing that the tenofovir alafenamide has the same efficacy and resistance with favorable side effects according to the bone and the renal. But I want to show you this, that the drug interaction and dose modification are not required in the elder renal impairment or hepatic impairment, but we are not justified to prescribe it in children before age of 12. Now, this is to show you that the interaction with other medicinal products are not an obstacle to use this by the primary care physician. The most common drugs used in Egypt with the chronic liver disease patient is the antidepressants, drugs against HCV, as well as oral contraceptives. They need no dose adjustment of either drugs, tenofovir alafenamide, or those drugs. So how to choose HPV therapy, which is a clinical utility for older patients and or patients with bone or renal disease. The indications for using entecavir or TAF over TDF is the age, over 60, bone disease, whether chronic use of a steroid or other medicines that affect the bone, history of fragility, fractures on the osteoporosis. Don't forget here post-menopausal women, which are exposed to many osteoporosis and osteopenia, renal abnormalities with decreasing glomerular filtration rate, increasing albuminuria, either more than 30 milligram or moderate proteinuria, low phosphate, or the hemodialysis. So in this condition, you are justified to use entecavir or TAF. But when to prioritize TAF over entecavir? When a patient with a previous nucleotide or nucleoside exposure, which is our situation in Egypt, we use lamivudine for long periods of time, and sometimes before the introduction of tenofovir, we used to add adivovir on lamivudine, and this is our situation in Egypt, HIV and HBV, but no dose adjustment for creatinine clearance, 15 millimeter per minute. So now TAF is preferred over entecavir. You prefer entecavir if it is less expensive when generics are available. I think that this is not our situation because there is no difference in price really between different drugs in Egypt and the dosing guidelines. So additional consideration I'll show you about TAF in some special patient subgroups. In the decompensated cirrhotic patients, it is preferred to use entecavir or the old tenofovir because the safety of the new drug is not tested for. But if this patient have, in addition to his decompensation, a renal impairment and or bone disease, especially if he's previously exposed to lamivudine or adivovir, you have now to use TAF. Data of pregnancy and the children is not lacking, so is not present or lacking, so we are not justified to use this drug in pregnancy or with children. So the key take-home points is never stop HBV treatment in any patient with cirrhosis or E antigen negative patient. So you use the drug that this patient will use lifelong, and this patient will grow up with this drug, and he will develop various diseases and various medications, including renal, bone, and drug-drug interaction. So you must use the safe drug. How to use in a multidisciplinary team. Incorporation of a specialistic care of comorbidities will help to reduce the risk of future liver morbidity. I'll show you an example called ecosystem. This ecosystem is the extension for community healthcare outcomes that was adopted in North America in rural and underserved areas to provide the patients here with the best practice in absence of sufficient number of hepatologists, and this includes using technology, best practices, case-based learning, and outcome tracking to train the primary care clinician to manage those patients of viral hepatitis and liver disease. So I think that we must adopt a similar policy or system to deal with hepatitis B virus among other chronic diseases, hepatic or non-hepatic, to overcome the difficulties already shown in this topic, namely how to deal with older patient, polymedicated patient with renal or bone disease, patients who are already exposed to nucleosides analog, and the widespread treatment with simple, safe, available, one-size-fits-all drug by the primary care physicians with available consultant when needed is the key to provide best care to our patient. And I want all of you to adopt this policy for the public health and the governmental perspective. Thank you very much for your attention.
Thank you, Professor Hassan Hamdi, for your great